Now the third thing that I'm going to tell you, if you guys can answer, it means that you have understood physiology very well. The third thing that I'm going to tell you is paradoxical aciduria. Now I had seen this question somewhere when I was preparing and no one was able to answer this. It was very sad to see that you guys have forgotten your physiology. Why do you feel there is paradoxical aciduria? Let's cue you into something more. What are the electrolyte imbalances that we see in case of your pyloric stenosis? What are the electrolyte abnormalities that you see? Low Cl. Okay, so let me put it. Hypokalemic, metabolic alkalosis. So I have done the easy part for you guys. I have done the easy part for you guys. Now what I want you to do is you have to tell me the mechanism of why hypochloremia, why hypokalemia, why metabolic alkalosis, and why paradoxical aciduria. Let me make this a bit tougher. Let me make this a bit, so vomiting, okay, alkalosis. The patient is vomiting. Let me do the easy part again. So hypochloremia. Let me first talk about hypochloremia. Now I want you guys to just listen to me. Open your ears, listen to me, and trust me, after this, even your physiology will be strong. Yeah, just listen to me. So let's talk about hypochloremia first. So what's happening is because of vomiting, you are losing your stomach content, which is nothing but HCl, right? So you're losing H plus and Cl minus. So metabolic alkalosis because you're losing H plus and hypochloremia. This is the easy part. This is the easy part. There is metabolic alkalosis and there is hypochloremia because when you're vomiting, you're losing H plus and you're losing Cl minus. So this is the easy part. We are done with hypochloremia. We are done with metabolic alkalosis. Now is where the tough mechanisms come into place. What is happening is since the patient, do you guys know that in our collecting ducts and in the distal DCT, you have two cells, intercalated A cells and intercalated B cells. What they do is these are the cells that help the kidney to regulate the acidosis and alkalosis. So when a patient has alkalosis, what they do is they try to compensate it with acidosis, right? So intercalated A cells in the base, and then we'll talk about it. Intercalated A cells and intercalated B cells. So when the body's acid is low, intercalated A cells will be used. When the body's base is low, intercalated B cells will be used. And that is very easy to remember. A for acid, B for base. Perfect. Now let's see what's happening. So can I say two things are happening when a kid has congenital hypertrophic pyloric stenosis? One is that the kid has alkalosis. Just listen to me. Stop answering. Listen to me. Stop answering and listen to me. Alkalosis. Second is dehydration. We'll have time for questions. So you have alkalosis and you have dehydration. Now what will happen in alkalosis is the kidneys will try to compensate. How will it compensate? It will try to excrete bicarbs. Correct? If I'm losing H plus, how can I compensate the alkalosis? I'll excrete bicarbs. So if bicarbs low, acid low at the end, plus minus, it all goes. How will it do this? So there are I just told you there are intercalated alpha cells, right? So what happens is in these cells, what the body will try to do is it'll try to take the potassium inside. Now now before I start with this, let me cue you in dehydration. What happens in dehydration is when you have dehydration, two things are going to happen. One, there is activation of ADH, and there is activation of RAS. I saw someone answer RAS, which was a very good answer. And there is activation of RAS. Renin, angiotensin, aldosterone system. What is the function of RAS? Very simply, if I have to tell you, the two function of RAS is first, retention of or reabsorption of sodium and water. And second is excretion of potassium and H plus. Very simply, very simply. So patient has dehydration, RAS got activated. Why RAS got activated? Because you want to save water. Because the patient is dehydrated. Wherever sodium goes, water follows. In the kidney, in the nephron, wherever sodium goes, water follows. So if I have to pull water in, I have to pull sodium in. That's it. As simple as that. Now I just can't pull sodium in, sodium just come inside. No, I have to give also something. So what I do is I give K plus and I give H plus, right? So this is the barter system that is going on. And what does ADH do? What does ADH do? ADH causes reabsorption of water through what? Through aquaporins. Now, why is this important? You have to understand. So this was using K plus as a barter system. So if I'm pulling in Na, I'm giving out potassium. Do you guys understand this? Please understand this. If I'm pulling in sodium, why am I pulling in sodium? Because where sodium goes, water follows. But I also have to give something. So to get that sodium inside, I'm giving potassium. But for ADH, ADH is going to activate aquaporin. ADH does not require sodium. ADH will directly catch hold of water, pull it inside. That's it. So are these two things understood to you? So can I say that here, let's take a very rough example. If I'm pulling 10 molecules of sodium with 10 molecules of sodium, I'm getting 10 molecules of water also. Yeah. But here I'm getting 10 more molecules of water. So 10 plus 10 is what? 20. 20 water I have and only 10 sodium. So can I say this is dilutional hyponatremia? So this is how there is hyponatremia in a patient with hypertrophic pyloric. You have to understand because AMC does ask questions. I'll show you the question that they asked and how they asked. Do you guys understand how this is dilutional hyponatremia? Is this clear? Yeah? Understood? Okay. Pujal, I'll repeat it. So my patient was dehydrated. In order to counteract that dehydration, I activated two things, RAS and ADH. What RAS did is reabsorption of sodium and water and excretion of potassium and hydrogen. Why? Because you have to understand that in your kidney, wherever sodium goes, water follows. So now if I want to pull 10 sodium inside, I need to give 10 potassium outside. Now with this sodium, even 10 water is coming in. Okay. But what ADH does is, ADH does not require sodium to pull the water. ADH directly activates aquaporins in the collecting ducts. Aquaporins catch hold of water and pull it in. So aquaporin directly pulled 10 molecules of water inside. Okay. So now what happened? I have 20 molecules of water, but only 10 molecules of sodium. So this in itself is a dilutional hyponatremia, right? It's like I have one lemon, one glass of water. I squeeze the lemon in one glass of water. I have a very tasty drink. Now I put the same one lemon in three glasses of water. You think that lemon is going to taste at all? It won't, because the water is a bit too much, right? So there is dilutional hyponatremia. So we are done with metabolic alkalosis. We are done with hypochloremia. We also understood why there is hyponatremia, right? Now, if you see, now if you see the alpha intercalated cells, also what they are doing is they are pulling in sodium. They are pulling in sodium. Now, what did I tell you? In order to pull in sodium, what do I have to give out? Potassium, correct? I have to give out potassium if I want to pull in sodium. Yes. But do I have potassium? Because my RAS has already exhausted my potassium. Potassium is gone. So what does alpha intercalated cell do? It pushes out H plus instead of K plus. So now when I'm pushing H plus inside the lumen, what am I doing? In the urine, I'm losing H plus, which should not have happened because I want to protect H plus, but I'm giving away H plus. This is why this is called paradoxical aciduria. What it means is aciduria should not be happening, but it is happening because of certain mechanisms. So this is what is paradoxical aciduria. Understood? Perfect. Is the physiology in line now? Yeah. Thank you. Thank you. Thank you so much. So now let us solve some questions. Yeah. Thank you. Thank you. Thank you so much. Thank you so much. We'll, I'm blushing.